Hello, everyone, and many thanks for asking me to come, and it's an honor to debate Bill, but I think we probably will end up having some kind of consensus at the end of the debate. But I'll try to give my thoughts on fixed duration treatment versus continuous, when and why. My view is that I would like to state that fixed duration treatment is the way forward, continuous is the past. And in terms of defining fixed duration treatment for CLL, we have been using fixed duration treatment for a long, long time now. So chemoimmunotherapy is and was always fixed duration. It was never a continuous treatment for our patients. Now, currently, we have got this availability of two options in the frontline CLL treatment landscape. First option, which is becoming a bit old now, is venetoclax, which is given orally, and that is combined with the venetoclax given over 12 months. And then we now have got the other option where we're combining ibrutinib with the first 3 months lead-in, and then a combination with venetoclax for 12 months. So we've got 15 months in total. And we've got one option in relapsed CLL, which is venetoclax, which is now given over 2 years, and then we combine that with rituximab for 6 months. So that's kind of, in most jurisdictions, these are the available treatments for fixed duration treatment option. And when to use fixed duration therapy, I think it's pretty clear, and I think probably Bill will say the same thing, is that only when there is clinical indication, because we know that a third of our CLL patients do not need treatment, and in those patients, we shouldn't treat them. And I would argue that it is suitable for any age group, and I would just like you to focus on the patients who have kindly participated in these pivotal trials. So, for example, CLL14, our median age of patients who got venetoclax and venetoclax was 72 years, and we know that our patients, the age of diagnosis is 71, the median is 71. And in GLOW, it was again 71 years. And when we look at the younger population, the CLL13 had patients where the median age was 61. So really, I would argue that most of the patients will actually benefit from fixed duration therapy. And it's also suitable with patients who have got comorbidities. So when we look at CLL14 and GLOW data, we know that this analysis that we do called the Cumulative Illness Rating Score, which is also called the SIR score. And the higher the score is, the more comorbidities the patients have. And majority of the patients who went on to these studies had a very high SIR score. And I think the last thing is when you talk to a clinician, which becomes important to us, that the genetic disease status becomes very important rather than age or comorbidities. And that is defining the outcomes with fixed duration therapies at this moment in time. So why fixed duration? I think I put the caveats in for physicians and then for the patients. For physicians, it's important that there's limited exposure to drugs. We are able to induce deep remissions in our patients. And they are really active in all genetic subtypes, providing some of the high-risk diseases, high-risk disease areas. Yes, the outcomes are definitely inferior. But there is opportunity for immune reconstitution. And what does that mean? It means that once we stop therapy, the immune system has got a chance to recover, and actually people are able to cope with infections better when they are off therapy. And the other thing is very important because we've got these new drugs, but essentially repeating the treatment is possible as well. So if some patients relapse after fixed duration therapy, we can actually repeat that treatment. And the last thing, biologically, there is very low risk of resistant mutations, at least to the data that we've got up till now, to the targeted drugs when we are using the fixed duration approaches, not the continuous approach. And for patients, there is an end in sight. So, if I tell you that after 12 or 15 months, you're going to stop therapy, I think there is an end in sight. But I do tell that essentially there would be early pain with a lot of blood test monitoring, but there's a lot to gain later on. And this may be the only treatment you may need in the whole CLL journey as well. And I think for some patients that might be true. And there is scope for reduced long-term toxicity, and we're now accumulating more and more long-term data. And I've just put down there as it might be a bit provocative, but the functional cure might be possible in some patients, and by that mean that one treatment, and hopefully we won't have to treat the patients again. And the only other slide in which I will briefly talk about is continuous therapy. When we say continuous therapy, it's not really continuous for everyone. So if you look at the data for Elevate-TN study, which was an acalabrutinib-based study, and I've only put that study in there, 50% of the patients had actually stopped therapy at 6 years. That might be due to adverse events, that might be due to disease progression, that might be due to other factors. But nearly half of the patients are not continuing the continuous therapy. The other thing we have to realize is that real-world evidence is slightly different to what we see in the clinical trials. So I've just put down the US real-world registry data, and there are 3 BTK inhibitors there that are mostly used: zanubrutinib, acalabrutinib, and ibrutinib. And none of the BTK inhibitors are being taken for more than 3 years. So what you find actually with continuous therapy, there is a lot more dropout in real world as compared to when we see in the clinical trials. And with continuous therapy sometimes comes cumulative toxicity. And if you look at the meta-analysis looking at infection risk or immune recovery, the infection risk remains the same, really, whether you've seen the fixed duration therapy or continuous therapy. And last one is very important as well. It is a cost-effective model for the different healthcare systems as well. With continuous therapy accumulating costs over time, that is a real issue for the healthcare systems. So this is the final really slide, and I think this is a very, pictorially it's been shown quite nicely in this, that if you look at different markers in physicians' view, and you've got this balance in tilting towards one way or another, this is a nice paper looking at this question. And really, if you look at undetectable MRD, fixed duration is better. If you look high cardiovascular risk, fixed duration is better. Retreatment, fixed duration is better. Infection risk, pretty much parity. You're looking at complex karyotype. And then you've got other things, I can't see from here. TP53 mutation, where continuous therapy is better, but IGHV unmutated or mutated patients the same. And then you're looking at the targeted mutations that I've talked about, and again, the fixed duration therapy, the risk of accumulating mutations. So I would argue that actually there are more balances towards this fixed duration approach in my cartoon. So I think I will stop my part of the argument. Hope I've convinced you that fixed duration therapy trumps continuous therapy. I think logically, scientifically, economically, and pragmatically. I rest my case.
Great. Good morning. So if you're familiar with the work that I've been involved with over the years, you'll probably understand that I am definitely aligned with time-limited therapy, fixed duration therapy, my interest in MRD, et cetera. So this is a little bit interesting of a presentation for me because I'm sort of arguing the other side of the coin. And I tried to think of an analogy. It would be something similar to an airline pilot trying to convince you that traveling around the world to sightsee is better done by other modes of transportation than by airplane. But be that as it may. I have 2 important slides. One is the first one, and then the other important slide, and then I have a lot of data slides in between. The other important slide is sort of some of the highlights of fixed duration therapy and challenges I think we have with the fixed duration therapy. So these are some of the items that support continuous BTK inhibitor-based treatment for patients with CLL. So one of my other roles is I chair the NCCN panel in the US, and we have lots of discussions about treatments and treatment options and making treatment options available for our patients. And so this is sort of a discussion, and we'll talk a little bit more about the challenges we have come up against with fixed duration treatment. But starting with continuous therapy, this is BTK inhibitor-based therapy. One thing that I should remark on first is that for both continuous treatment and for fixed duration treatment, randomized clinical trials have shown clearly benefit for BTK inhibitor-based therapy or venetoclax BCL2 inhibitor-based therapy over chemoimmunotherapy. And some of those trials have shown improved overall survival. And so there's no question that small molecule inhibitor-based therapy is superior over chemoimmunotherapy. Unfortunately, that's not necessarily, as we heard yesterday, an option for much of the world, which is unfortunate, and hopefully we can work on strategies to make these treatments available for everyone, because I do believe that that's extremely important. So continuous BTK inhibitor-based therapy is very easy to treat with. Patients go on these drugs. They require minimal monitoring. They stay on the drugs. We intermittently see the patients. They do relatively well. We'll talk a little bit about the side effect and toxicities that we see. But they're pretty easy drugs to use if you're talking about treating patients in the community and don't require a lot of frequent visits and monitoring with labs, et cetera. They don't require the ramp up that Tahla didn't talk about with venetoclax, and the longer term monitoring, again, as I mentioned, I mean, you have to see patients in follow-up, but it's not as intensive as with venetoclax-based therapy. We have very good long-term outcome data with the small molecule inhibitor, BTK inhibitor-based therapies, where we know the median progression-free survival with ibrutinib, for example, was just reported at 9 years in the frontline setting. So they work very well, and they work for long periods of time. But they do require continuous therapy, so that is a drawback. They have activity and work well in patients who we used to consider high-risk patients. Now, the progression-free survival is shorter for patients with 17p deletion mutated TP53, but they do much better than they did with chemoimmunotherapy, and you can get better disease control long-term with BTK inhibitor-based therapy for patients with 17p mutated TP53 than you can with fixed duration therapy, at least today. Ibrutinib and the others work very well in patients with otherwise considered high-risk features of unmutated immunoglobulin gene and 11q deletion. We don't think of those as high-risk patients like we used to in the days of chemoimmunotherapy. We know the side effect and toxicity profile, and I would say that it is, for the most part, manageable. So we know what we're dealing with these agents, and we know what the outcome is. There are second-generation drugs. So the first generation is ibrutinib, second generations being acalabrutinib and zanubrutinib. They appear to have a bit better safety profile. But again, we are familiar with the side effects and toxicities. And we're talking now about trials and doing trials with intermittent treatment with these agents. Can you give patients a break? So we have a trial at MD Anderson. Two trials, actually, one with zanubrutinib and one with acalabrutinib, where patients get 2 years of treatment, fixed duration, and then they stop, they have a break, and then they can restart if the disease grows again. So like I said, the next slides sort of support these statements and are the data slides. I'm going to go through them relatively quickly. I think probably many of these results you have seen before and are probably familiar with the outcomes. The RESONATE-2 was the frontline trial of ibrutinib versus chemotherapy, chlorambucil, which showed superiority for ibrutinib and led to the approval in the US of ibrutinib in the frontline setting. And as I mentioned, just recently we heard the median progression-free survival with ibrutinib in the frontline setting is 9 years. That's exceptionally good. it does require continuous treatment. And if you look to the right, those top two curves that are superimposed are patients with a mutated versus unmutated immunoglobulin gene. So it works equally well in patients with a mutated versus an unmutated immunoglobulin gene. Also, on the left, you see outcomes for patients with and without 11q deletion, and it works very well in patients with 11q deletion. The data on the right is the same data for IGHV mutation status. And then this was a combined pooled analysis of patients with 17p mutated TP53, frontline ibrutinib-based treatments, and you can see on the left progression-free survival and on the right overall survival, exceptionally good outcomes for patients with that high-risk feature. It's a bit more than 6-year median progression-free survival. Overall survival, we don't have a median, but you can see that those patients are doing very well. These curves would not look anything like this if we were talking about chemotherapy. And in the olden days, when we were giving chemotherapy, when we were giving treatments like FCR, we would be, if we had a set, even in the frontline setting, if we had a patient with 17p deletion, mutated TP53, we'd be saying, okay, what's the transplant options for this patient? I need to get that sort of duck in order because I know that's coming soon. Today, we don't think that way because we have these good treatments that work for that high-risk population. So the second generation BTK inhibitors have been developed and are now approved. The Elevate-TN trial led to the approval of acalabrutinib in the frontline setting. This is a randomized 3-arm trial of acalabrutinib, which is a second generation BTK inhibitor, as monotherapy or with a CD20 antibody, obinutuzumab, versus chemoimmunotherapy. In this case, it was chlorambucil obinutuzumab. And you can see the acalabrutinib arms performed much better in the progression-free survival curves on the left than the chemoimmunotherapy, which is in green. And again, we see improved outcomes and sort of elimination of these high-risk categories of unmutated immunoglobulin gene. And again, good outcomes for patients with TP53. In this trial, there was improved progression-free survival, as you can see in the blue curve there, for patients who received acalabrutinib plus the CD20 antibody. So this is something that we talk about, what's the value of adding a CD20 antibody in this setting. There could be value, again, this is continuous treatment. There could be value by intensifying and getting patients in a deeper remission early on with this continuous-based therapy, but that's a research question. Overall survival looks great, and these curves extend out 8 years or so. Side effects and toxicities, I'm going to touch on those for a couple minutes. So the main ones that we worry about are listed here. Cardiac toxicity, atrial fibrillation. It's uncommon, less than 10%. It's lower in the second generations based on randomized clinical trials that have been done, but it is a concern with this strategy of treatment. These drugs also act as blood thinning agents. They inhibit platelet function, and so patients can have increased risk for bruising and bleeding on these medicines. And long-term, we see hypertension develop in patients who've been on these drugs for several years. So again, we have many years of patients and many patients on these treatments, so we do have a good idea of what the side effect and toxicity profile is, and I believe that those are reasonably well managed. Sequoia was the randomized trial looking at zanubrutinib in the frontline setting and showed superiority for zanubrutinib versus chemoimmunotherapy. In this case, it was bendamustine rituximab. That's shown here in the progression-free survival. Similar overall survival between these two treatment arms, but these patients are doing exceptionally well long-term, and also with zanubrutinib, similar side effect and toxicity profile that we worry about with these agents, but again, that I believe are manageable. So those are my comments on continuous treatment. Now, the challenges with time-limited therapy are the difficulties with initiation and ramp-up of venetoclax and the monitoring that needs to be done for patients. This has limited its application in the U.S. where my preference is for time-limited therapy, but most patients these days, the majority of patients in the US are getting continuous treatment. I think that will change with the randomized trials that we have and the data that we have that's coming forward, but this is the big challenge. And yesterday we heard about other countries where it's hard to get a blood count. And if we're talking about the monitoring for ramp-up, I think this will limit the generalizable, the general applicability across the world for the time-limited therapies. It is somewhat laborious in terms of the frequency of visits and the monitoring that needs to be done, and monitoring for neutropenia and management of neutropenia. What are the optimal patient characteristics? The treatment regimen, do we give doublets, do we give triplets, and what's the optimal duration of therapy is unclear. We need to clarify that with clinical trials. It is immunosuppressive if we're including the CD20 antibody, so that is a challenge. It's been a challenge in the COVID era, it's remaining a challenge, and we worry about the immune status for our patients. We don't know what the expectations are for retreatment, so maybe some of these patients who are getting these new combined targeted strategies are cured, but we worry about what options are left afterwards. And we also worry about patients who have high-risk features not being on sort of a maintenance where bad things can happen to their disease if their disease is left unchecked and growing. So with that, these are just a summary of my points. Thank you for your attention.